Dear doctors, I believe your preparation for EDIC Part 1 is going on well. So let's kick in for today's next set of questions.
Question 1. A 54-year-old man with septic shock is receiving broad-spectrum antibiotics. After 72 hours, his CRP remains elevated, 240 mg per liter. Procalcitonin has decreased from 12 nanogram per milliliter to 2 nanogram per milliliter, and lactate has fallen from 4.5 to 1.8 millimole per liter. Which interpretation is most accurate? Persistent infection is likely. Antibiotics should be escalated. B. Clinical improvement is indicated despite high CRP. C. Decreasing procalcitonin suggests fungal rather than bacterial infection. Lactate clearance is unreliable as a prognostic marker in sepsis. CRP trend is more reliable than PCT in assessing treatment response. Correct answer is B. Clinical improvement is indicated despite high CRP. Explanation: CRP lags behind clinical improvement because of longer half-life. PCT falls more rapidly with control of bacterial infection. Decreasing values indicate treatment response. Lactate clearance is a reliable prognostic marker in sepsis. Persistently high CRP alone is not an indication to escalate antibiotics. Question 2. A 45-year-old male with severe traumatic brain injury is monitored with ICP and brain tissue partial pressure of O2 probes. Current values: ICP 18 mm of mercury, CPP 65 mm of mercury, PbTO2 14 mm of mercury. Which intervention is most appropriate? Increase CPP by vasopressors. B. Initiate hyperventilation to reduce ICP. C. Give hypertonic saline to reduce ICP further. D. Optimize oxygenation and hemoglobin concentration. Decompressive craniectomy. Correct answer is D. Optimize oxygenation and hemoglobin concentration. Explanation: ICP less than 20 currently acceptable. CPP 65 within target range. Low PbTO2 less than 20 mm of mercury suggests poor oxygen delivery at tissue level. Increasing CPP further may risk hyperemia. Hyperventilation may worsen cerebral ischemia. Best step is to optimize systemic oxygen delivery, partial pressure of arterial oxygen, HB, cardiac output, before invasive measures. Question 3. A 58-year-old female with septic shock on mechanical ventilation has the following ABG. pH 7.32. Partial pressure of arterial CO2 28 mm of mercury. Bicarbonate 14 millimole per liter. Sodium 140, chloride 110, albumin 20 gram per liter, lactate 8 millimole per liter. Which statement is most correct? Simple metabolic acidosis due to lactic acidosis. B. Mixed metabolic and respiratory acidosis. C. Mixed metabolic acidosis and metabolic alkalosis. D. High anion gap metabolic acidosis with additional hyperchloremic acidosis. Normal anion gap metabolic acidosis. Correct answer is D. High anion gap metabolic acidosis with additional hyperchloremic acidosis. Explanation: anion gap equals sodium minus chloride plus bicarbonate equals 140 minus 110 plus 14 equals 16. Corrected for low albumin, add 6 to 1622, it is elevated anion gap. High lactate, 8, explains high anion gap metabolic acidosis. Delta gap, 22 minus 12 equals 10. Expected bicarbonate equals 24 minus 10 is equal to 14, matches actual bicarbonate value of 14. But chloride is elevated, 110, with hypoalbuminemia suggests superimposed hyperchloremic metabolic acidosis. Question 4. A 60-year-old man with septic shock is on norepinephrine. PICO values. Cardiac index, 2.4 liters per minute per square meter. Global and diastolic volume index, 850 milliliters per square meter, normal. Extravascular lung water index, 15 milliliters per kilogram, elevated. Stroke volume variation, 9%, low variability. Which is the most appropriate management step? Give fluid bolus to increase preload. B. Start dobutamine to augment contractility. C. Escalate norepinephrine to increase afterload. E. Administer diuretics or consider continuous renal replacement therapy. E. Perform passive leg raise to assess fluid responsiveness. Correct answer is B. Start dobutamine to augment contractility. Explanation. Cardiac index 2.4 liter, this is low cardiac output. Global end-diastolic volume index is normal, preload is adequate. Extravascular lung water index is elevated, fluid overload or poor cardiac contractility. Stroke volume variation low means not fluid responsive. Best next step, inotrope, dobutamine, to improve cardiac output. Diuretics or RT may help later, but low cardiac index must be corrected first. Question 5. A 70-year-old male, day 2 after pancreaticoduodenectomy, develops hypotension, MAP 55 mm of mercury, and tachycardia, heart rate 118. He is oliguric, urine output 0.2 ml per kilogram per hour, and mildly hypozemic on 40% FiO2. Bedside diagnostics. Echocardiography, LV end-diastolic volume index, 55 ml per meter square, low. Hyperdynamic LV contractility, no pericardial effusion. IVC assessment, collapsible 30%. Lung ultrasound, patchy B-lines in lower zones bilaterally, with small right pleural effusion. Left ventricular outflow tract VTI variability, 17%, which is the most likely underlying cause of shock. Hypovolemic shock from occult intra-abdominal bleeding. B. Septic shock with vasoplegia and secondary pulmonary edema. C. Cardiogenic shock due to left ventricular dysfunction. Obstructive shock due to evolving pulmonary embolism. Mixed shock state, relative hypovolemia with fluid overload. Correct answer is E. Mixed shock state, relative hypovolemia with fluid overload. Explanation. Left ventricular end-diastolic volume index, 55 ml per square meter suggest low preload or underfilling. Hyperdynamic LV supports underfilling rather than pump failure. IVC collapsibility 30% plus VTI variation 17%, borderline fluid responsiveness. Patchy B-lines plus pleural effusion, pulmonary edema or fluid overload, likely due to capillary leak or prior resuscitation. Pattern suggests mixed physiology, relative hypovolemia with pulmonary edema, common in complex postoperative sepsis-like states. Question 6. A 54-year-old woman with septic shock due to pneumonia is on norepinephrine, 0.25 microgram per kg per minute, and mechanical ventilation, FiO2 0.5, PEEP 10. On day 3, she develops jaundice and rising liver enzymes. Labs, aspartate aminotransferase, 980 unit per liter, alanine aminotransferase, 1050 unit per liter, alkaline phosphatase, 135 unit per liter, slightly elevated, total bilirubin, 165 micromole per liter, predominantly conjugated, INR, 2.3, lactate, 5.8 millimole per liter. Hemodynamics, picocardiac index, 3 liter per minute per square meter, normal, SVRI, 900 dyne, low. Global end-diastolic volume index, 710 milliliter per square meter, low normal. Extravascular lung water index, 13 milliliter per kg, elevated. Ultrasound with Doppler, patent portal vein and hepatic artery, no biliary dilatation. Hepatic vein Doppler, blunted systolic wave with diastolic predominance. Which is the most likely explanation for her liver dysfunction? Septic cholestasis due to cytokine-driven bile transport impairment. B. Ischemic hepatitis, shock liver, from hypoperfusion and hypoxia. C. Congestive hepatopathy due to right-sided heart dysfunction and venous congestion. D. Drug-induced liver injury, antibiotics or vasopressors. Acute biliary obstruction from sludge or stones. Correct answer is B. Ischemic hepatitis, shock liver, from hypoperfusion and hypoxia. Explanation. Very high aspartate and alanine aminotransferase, greater than 1000. Classic for ischemic hepatitis or severe toxic or viral injury. Low SVRI and ongoing septic shock, vasodilation with normal cardiac index. This is distributive shock physiology. High lactate supports inadequate tissue oxygenation. Hepatic vein Doppler showing blunted systolic wave suggests some venous congestion, but this usually causes modest enzyme rise plus cholestatic picture, not massive aspartate and alanine aminotransferase elevation. Septic cholestasis typically causes bilirubin rise more than enzyme rise, which is not the case here. Drug-induced injury possible, but the temporal profile, ICU day 3 in septic shock, and lactate elevation point strongly to ischemic cause. No biliary dilation rules out obstructive pathology. Thus, the dominant pathology is ischemic hepatitis in the context of septic shock, with venous congestion as a contributory factor.
Dear doctors, I believe the information given in this video was useful to you. If you have any feedback, suggestion or comments, or if you want to discuss any question or answer, please write down in the comment section where I will respond.